For the time, we'll not be able to have questions. We'll proceed for the third lecture with my colleague, Dr. Mansour. Please go ahead.
The third lecture will be the MPN management in pregnancy and in adolescent and young adults. And Dr. Naseema Gangat will be presenting today on this difficult patient population. Dr. Naseema has been introduced previously, and for the sake of time, we'll just go ahead with the presentation.
So we'll go ahead with the second lecture. This should be fairly straightforward since there's very limited data. So most of the information I'll share with you is my personal practice and experience. We'll skip these. We'll go through what are the characteristics of young patients with MPN, how to manage MPN in pregnancy, the Philadelphia negative ones, and then I'll briefly touch upon CML in pregnancy, since that's a very relevant topic as well, since it's more common than the other MPNs. So yeah, I'm just going to highlight that out of thousands of patients seen with MPN at the Mayo, 12% of patients were below 40 years of age. And among them, predominantly, the patients were essential thrombocythemia patients, and 69% of those were females, suggesting that there is considerable proportion of females of childbearing potential who have ET and who need a particular counseling, and management practices have to align with what aligns with fertility and childbearing. Patients with ET who are younger have higher platelet counts, which frightens everybody when you get a call from the lab that platelet count is over 1 million. They tend to be CALR mutated, which has a lower risk in terms of thrombosis. They have a high incidence of fibrotic transformation, particularly since they live longer for decades, and they have a low incidence of arterial thrombosis, which is expected for younger patients. And this is a duplicate slide from a prior presentation, that age is a very important determinant of survival. And as we expect these patients to live for decades with a near normal life expectancy, we also expect that these patients should be able to lead a normal life. Particularly, women should be able to have children and take care of their children. Just to sidetrack, a few special considerations in younger patients with MPN is patients with high platelet counts, the platelet millionaires, and patients with unusual thromboses, the splanchnic and cerebral vein thromboses. And we know the traditional risk factors for thromboses in ET patients, but I've once again highlighted in the slide here. So extreme thrombocytosis does not predict increased risk of thrombosis or hemorrhage post-diagnosis. If your patient has acquired von Willebrand's and signs and symptoms of that, then they need to be managed for that. But it doesn't necessarily, all patients with a platelet count over 1 million doesn't necessarily mean that they need to be treated with chemotherapy. And this is once again a difficult area because it is hard to find patients to follow prospectively given the long natural history of the disease. And particularly extreme thrombocytosis is not a very common entity. It's only in about 10% of patients with ET. And when we looked at the treatment strategies for these patients and to see if they were correlating with increased thrombosis of hemorrhage, we did not think that addition of cytoreductive therapy was in particularly beneficial for these patients or protected them. The number of events are very low in this slide. And of course, this is a retrospective design, so a lot of limitations associated with it. But to this day, this is the best data that is available. And I mentioned the unusual thromboses. Patients with splanchnic thrombosis actually have the highest risk for venous thrombosis recurrence. So even with treatment, so that means that that is an area that needs special investigation. And those are patients who need to be monitored very closely and continued on indefinite anticoagulation, particularly if there is no contraindication to stop the anticoagulation. So I'll summarize a few points here. For splanchnic thromboses, prefer the DOACs over vitamin K antagonist therapy. Consider aspirin if your patient has any risk factors for arterial thrombosis. And cytoreductive therapy is optional for these patients based on the blood counts. And then what about the patients with extreme thrombocytosis? It is best to kind of observe and stay put. There's no value of adding cytoreductive therapy without a clear indication, especially if they are low risk in nature and have had no prior thromboses. Investigate for acquired von Willebrand syndrome, and if that is present, we should avoid aspirin therapy. And I think I could not emphasize more to treat the patient and not the platelet count. So moving on to pregnancy in MPN patients, childbirth rates in MPN were found to be lower compared to control population, but patients with ET seem to have a normal childbirth rate compared to the normal controls. And this was based on a large Swedish case control study. And here are some of the features of the pregnancies that they described. This was recently published about 2 years ago, and this is kind of the largest population-based study on pregnancy in MPN to date. And how did these patients and the fetuses do? So the low birth rate and the preterm deliveries were higher in MPN patients compared to controls. So that is to be noted and should be used when we're counseling our MPN patients. And then, of course, what about the maternal complications? There was no difference in maternal thrombosis rate. There was a trend for increased bleeding in these patients, but the treatment data for these patients were not available since it was a population-based study, so hard to correlate in what situations these events occurred. So how about our own experience? So I've followed over 200 pregnancies and 100 women with ET retrospectively over the decades. And what we found that the childbirth rate was actually quite fairly high. Only about 28% ended up in fetal loss, which is quite similar to the normal population. Granted, this was not control data. And then when we stratified it by treatment with aspirin versus no treatment, clearly treatment with aspirin was protective against fetal loss. And the good thing to note is that patients' platelet counts do decline with pregnancy. So even if your patient is young with type 1 CALR mutation and has high platelet count, by the time they get to the third trimester close to delivery, the platelet count nadirs. And as you can see, the median platelet count in the third trimester was down to 369, and it starts to come up postpartum. So we have to be vigilant about thrombosis. And this is just a summary of all the data that aspirin was beneficial for fetal loss. The main predictor of fetal loss is a prior fetal loss. So those are the high-risk pregnancies. And CALR mutation may be associated with major hemorrhage, particularly if there is acquired von Willebrand's. Oops, let me go back. I don't know if I can go back. So this is data I collated from all the studies that have been conducted on pregnancy in ET to date. And as you can see, even if you combine all the data, the live birth rate is 71%. First trimester losses is the main concern. Maternal complications in about 10% of the patients, particularly bleeding complications as opposed to thrombosis. So here are our management recommendations. The low risk and the very low risk patients with ET, aspirin alone. Aspirin alone actually for all pregnancies except for the high risk patients, they would require cytoreductive therapy to begin with. And interferon is the preferred agent because it does not cross the placenta. It's safe during lactation as well. We usually recommend stopping hydrea and have younger patients on interferon-based therapy to begin with. And in the antepartum phase, stop the aspirin about 3 days before delivery. And if they're on low molecular weight heparin, stop it about a week before delivery. And there's no clear data on whether to use postpartum low molecular weight heparin. We usually evaluate that on a case-by-case basis. And in MF, pregnancies are less common. And as you can know, the majority of the patients were actually prefibrotic MF, which is akin to ET. Once again, the same kind of variables. Aspirin is protective, and prior fetal loss is the biggest predictor of a subsequent pregnancy loss. So evaluating the patient's obstetric history, having a multidisciplinary team are a key to management of these patients. And I think I'll leave you guys with this algorithm, which covers both ET and PV. PV and ET are sister diseases, so I'm not going to go through PV in detail. The PV and pregnancies are also less common since patients with PV are older compared to ET. The only difference would be hematocrit control, particularly keeping the hematocrit below 45. But in pregnancy, there's a dilutional effect, so the hematocrit is going to be lower for these patients to begin with. How about CML and pregnancy? I kind of broke it down into scenarios because there are different situations, whether your patient has an established diagnosis, whether they get diagnosed during pregnancy, etc. So this is the most difficult scenario, that the CML is diagnosed while the patient is pregnant. So the decision to treat the CML depends on the phase of the disease, whether the patient's counts are very high depending on how the patient is presenting. But interferon is once again safe to use during pregnancy and lactation. The use of DKIs during the first trimester are to be avoided, but can be used in the second trimester or later. The TKIs that are safe are imatinib and nilotinib, and asymptomatic patients might be observed till they deliver. And if your patient becomes pregnant while on TKI, then the TKI should be stopped at the first pregnancy test. And these patients typically do okay based on the data because early exposure is associated with a low risk of teratogenicity. And it doesn't mean that the patient needs a therapeutic abortion, but it depends. If it's presenting with blast phase CML, then the situation might be different. And then if a CML patient is interested in a future planned pregnancy, then it's relatively easy because you can wait till they've reached the treatment-free remission criteria, and it can be more controlled because they would in any ways be eligible to discontinue treatment at that point. So that is a much more straightforward scenario. And how about the male partners on TKI? There is minimal effects on fertility. There is some studies looking at the spermatogenesis, et cetera, but in terms of fetal development, there have been no issues associated with it. That's why the focus has been on female patients with CML, and male patients do not necessarily need to stop therapy to conceive. So I'll be able to summarize this quickly here since there was very limited data, and most of the data I shared was our own personal experience at the Mayo. Preconceptual counseling is key for young patients with MPM, particularly the younger women. There is limited data to guide management. So here the art of medicine comes into play, and we really have to individualize the situation, and it's a very case-by-case management. Low molecular weight heparin use only if there's a venous thrombosis history. I do not routinely prescribe it just because somebody is pregnant or they need to be on it. And I think that also has to be looked at in a case-by-case basis. Aspirin is the cornerstone of treatment. To be careful about aspirin use if there is extreme thrombocytosis, and interferon is the safest drug to use, both for CML patients as well as the other MPNs. And I think more collaborative efforts are clearly needed in the area to advocate for our young patients who have a near normal life expectancy, so you expect them to be able to live a normal life as well. So I will stop here, and hopefully we can generate lots of good discussion after this.
All right. Thank you very much. We'll do a few questions. Any questions from the audience?
Thank you, Dr. Naseema. Very impressive and comprehensive presentation. I have two questions. The first is, do you consider pregnant women with prior history of fetal loss with no thrombotic events previously whatsoever as high risk or low risk? And how would you treat such patients, especially if they were in aspirin as a treatment? The second question, how long you experienced patients with extreme thrombocytosis without acquired Horner-Brand syndrome? Thank you.
So I'll go with the first one, and that's an important question that you brought about. If there's a prior fetal loss and if they've already on aspirin, I would consider those patients for interferon-based therapy because that would technically be a high-risk pregnancy. I think a lot depends on having the good records to be able to track what the prior obstetric history was. Sometimes those are missing. When patients come to a tertiary center such as ours, they may have had a pregnancy elsewhere. And it may be difficult to track, but I would definitely be more cautious. I wouldn't necessarily put them on heparin or low molecular weight heparin-based therapy, but adding the interferon therapy and being vigilant during the pregnancy would be my way to go. And for the extreme thrombocytosis patient without otherwise any high-risk features and no acquired von Willebrand's, it is reasonable to observe those patients. It is reasonable to continue on aspirin therapy cautiously. Just because platelet is over 1 million doesn't mean we should withhold aspirin. And the patients will tell you if they are experiencing any kind of excessive bleeding signs and symptoms, then we may be able to peel back because they would be at a lower risk for thrombosis anyways if they have a bleeding phenotype.
Excellent. One question is that?
When you talk about ET and polycythemia, high-risk patients, when you mention cytoreduction in high-risk patients, it's only an interferon that you can use in pregnancy. Is that correct? Or do you
Correct, correct. No other drugs are safe, particularly Hydrea. The data is not very clear, but I would avoid the use of Hydrea. In fact, for the younger patients with MPN in general, even if they are not telling you they want to get pregnant, it might be better for the young females, especially between the ages of 18 and 40, to be on interferon-based therapy in case they have an unplanned pregnancy.
One more question with Dr. Ayman.
MPL 106 Pro Leo here.
Oh, right there. Okay.
Okay, so the mutation of MPL Pro 106 Leo is quite common in this part of the world, and it's known to have thrombocytosis. Would you treat these patients? And we know for a fact, probably from experience, that these patients have lower incidence of thrombosis as compared to patients with ET, especially if they are JAK2 mutated. So what's your recommendation for such population? It's quite common in here. Is it the same recommendation that we go over, ET patients, or something different?
I think I'm going to once again underline that our recommendations are based on Caucasian patients, and if the MPL associated disease is more common here, I think I would extrapolate the information that I presented. But of course, I would be cautious looking at the patient's overall history, if there are other risk factors, et cetera. Just based on the presence of that mutation, I wouldn't necessarily change my approach to the patient, but I think I would be a little bit more cautious about it. Okay.
Excellent. Thank you, Doctor.
Thank you.